All right, so I'm going to partially plagiarize a previous talk that I gave, I guess 10-year anniversary now?
11. It's 11.
I know, but yeah. My 10-year anniversary for this talk, this was the first talk I gave at the New Orleans conference when it was in New Orleans. And at the end, we'll have a little bit of a discussion. We're just mainly posing some questions that kind of go along with the little bit darker side of Vegas and kind of just pose some questions that will stimulate some thought outside of medicine a little bit. So I have no financial disclosures. So as an overview, emboli can be a substantial health risk. We all know that in cardiac and vascular interventional procedures. Dr. Lumsden went over that as far as the transcranial Doppler imaging. Emboli can cause serious complications, and this was the first, and notice I scratched out only, intra-aortic filtration device, but from an open surgery standpoint, was a pretty popular device up until recently. And it may improve patient outcomes. The trend is toward that, and you'll see some data later on in the talk about that. Then we'll talk about why it also was pulled from the market and have some discussion on that. So the impact of sicker patients, sicker cardiac surgery patients, basically that correlates directly, in my opinion, and I think we'll all agree, with patients that have significant atheroembolic potential. And I think this number that increased from 1982 to 1989 is more related to our awareness and the implementation of ultrasound and better imaging modalities. So we've identified a problem, and now we're trying to fix it. And obviously we have those cases where you have the obviously easily palpated horrible disease when you open up, and you go from doing an on-pump case to, and if you're Dr. Bhatia, you're always doing an off-pump anyway, to where I have to go to off-pump. Not my favorite, but it is in my toolbox, and that's another discussion at the end by another speaker. So the atheroemboli have identified in 22% of patients, whether that's clinical or subclinical. This one particular paper looked at that, and 63% had multiple atheroembolic sites: brain, kidneys, liver, etc. Big toe, high correlation of atheroemboli with severe atherosclerosis of the ascending aorta. Obviously, because we're clamping, unclamping, and that's where we're doing the most manipulation and most invasive part of the procedure, including valve replacement and less so in coronary bypass in isolated cases. So the incidence of stroke by procedure, overall, if you have a CABG, there's a small amount, there's a little bit more with AVR, and you combine them and those numbers go up. Renal insufficiency. I'm going through these slides a little bit in essence of time, but also because it's a lot of common sense and just proven data points that have literature backing them up. So postoperative renal failure is a significant complication of cardiac surgery. And compared to renal dysfunction as defined by the STS, it's either dysfunction is a creatinine that's 2 milligrams per deciliter over normal, or 2 times the patient's normal creatinine. That leads to an associated mortality rate of 19%. And if you have outright renal failure, 63%. And again, this is just the renal aspect of it. And then, so type 2 neurological outcomes, type 1, being stroke, et cetera, the more hard symptoms of a horrible neurologic outcome. The type 2 are a little bit more nebulous, and pump head, memory loss, dementia, depression, delirium. And what we've seen is a discharge, if you have a neurologist do a thorough examination, because as we know, neurologists typically aren't very good at treating anything, but they're great at diagnosing stuff. At discharge, upwards of 50% have some kind of issue, dementia probably being the most common, and delirium being the most common. 6 months, that goes down, but then at 5 years, it starts creeping back up. Is that a product of getting older, or is it compared to a cohort higher than somebody who hasn't had cardiac surgery? So this has been subsequently revised, but in the guideline update for CABG surgery, postoperative complications should be a major concern. Renal dysfunction occurs in 8% of patients. with the aforementioned mortality rates, and then neurologic function occurs in a small percentage of patients, but still significant with an even higher mortality rate, especially if it's a stroke. Not so much with dementia, depression, and delirium, the Ds. So atherosclerosis plays a significant role in at least 2/3 of adverse events after coronary bypass. Perioperative atheroembolism from the aortic arch plaque is likely responsible for 1 in 3 strokes afterwards. I would probably say that's higher. And then significant atherosclerosis of the ascending aorta mandates a surgical approach. Well, fast forward, 2002, introduction of Embolic, and this is based on previous technologies where carotid stenting, coronary stenting, renal stenting, and re-interventional saphenous vein grafts had filter wires. So in the percutaneous embolic filter devices, these are examples. And then embolic protection techniques have evolved over time to reduce embolic complications. Beating heart surgery was supposed to be the end-all, be-all. Saw a huge swing in that technique being popular. It definitely still does have its role. It definitely does help with decreasing the manipulation of the ascending aorta. Epi-aortic scanning is still somewhat, in some institutions outside of a medical center, a little bit hard to push into your older surgeons or surgeons that have think they can put their finger on it and feel, oh, this aorta feels great here or not. Well, those soft plaques are really the dangerous ones, and those are the ones you can't feel. And if you ram a cannula right through it, you know what that's like. And if you have a transcranial Doppler going, everybody puckers up a little bit in those cases. And then femoral artery and axillary artery cannulation, another option. And some of the patients that have, say, a porcelain aorta and you're doing a single vessel or maybe have a soft spot, that does have a role in doing a beating heart without clamping. And then single aortic cross clamp technique I use in certain cases. So these are the older embolic reduction techniques and technology that were used. Proximal anastomotic devices really didn't bear out. That may or may not be related to use of epi-aortic scanning. Aortic balloon occlusion devices, dispersive tip aortic cannulas. I don't know who doesn't use those nowadays, but I guess when I was at Texas Heart, they still used the old bevel cannula. And then the Embolic glide protection system, which we'll briefly go over. So it was the first intra-aortic filtration device used, not first intra-arterial, but first intra-aortic. You've seen the pictures, really simple to apply. The only thing I would say when I would put it in, and I think most heart surgeons would realize in this room, is that you had to make the incision a little bit bigger, which in most of the cases, just so it would lie correctly, and then they called it the Mettauer. The Mettauer, the tower in the way that was getting in the way of the assistant when he was trying to help me with when that device was in place. Since then, TAVR, there's some newer technologies out there, not using necessarily filtration techniques, but deflecting techniques just to basically get it past the arch, the right, the innominate and the right common carotid system and the left common carotid system, and then kind of deal with the after effects distally. The Keystone Hearts TriGuard is one of those. Actually, Edwards had another similar device which got pulled for the TAVR, and then Embolic, which I believe is coming to market soon, or if it hasn't already, which is a pretty interesting device. It basically uses the same sheath that you do with TAVR, and it completely covers up the distal ascending aorta down to the descending, and has a reverse funnel-looking appearance, and it's made of nitinol that conforms to the aorta throughout, and basically when you squash the aortic valve with the TAVR, all that debris bypasses the arch and gets collected in the distal descending thoracic aorta and gets removed. You can all use it through the same sheath. Pretty interesting concept. And then most recently, the Claret Medical Sentinel filter, and we'll go into some of the detail about that afterwards for TAVR as well. A little bit more complicated to put in, but with the level of crazy things we're doing with TAVR and debranching, et cetera, it's really kind of just an extra step that really shouldn't be that difficult. And they have found it to be pretty easy to do. So we'll go past this. So just to reiterate, let's go back. So it offers 2 levels of protection. It basically has the dispersion tip and the filter. It's very safe. And the initial assumption was that it may prevent and improve patient outcomes. Anecdotally, there's no doubt in my mind that it did it. When you pull out a filter from an aortic valve and you pull out a index fingernail-sized thrombus, not thrombus, but a plaque, there's not much in the way of denying that didn't prevent some major complication. If it made it past the first stop, which is your right brain, second stop, left brain, then you can imagine where else it can go. And we've all seen these pictures. 99.1% of all of the filters that were examined by Edwards, I have a whole email folder full of these, always had something. Some were insignificant, some had debris. I mean, I'm convinced pieces of, exactly, frayed proline, stuff from towels. I mean, it was all kinds of interesting things in there. And like I tell my patients, remarkably, the heart can handle some microemboli and some macroemboli. When you stent it, so can the kidneys to some degree and most other organs, including your toes. We've seen all those patients that filter out that stuff in their toes, and then they miraculously don't lose all that tissue that you thought they would. But the brain is a very good filter. There's not really a lot of places for it to go. You just hope it goes somewhere where it's not very important. Like, would you say, 3rd grade? Right. So just look at some more of these pictures, and then authors with looking at the embolic capture with the Embolics, studies of upwards of 2,300 showing 98% capture of something. And all of the ones I did, which is probably about 400, 450, I had something. I was 100%. So patients without a filter are 2.7 times more likely to experience an adverse neurologic event. Now, that's a broad definition, and that goes from anywhere from being the delirium, the depression, et cetera, to an outright stroke. This was a study by Schmitz put in the Journal of Thoracic and Cardiovascular Surgery in 2003. Didn't really meet statistical significance, but definitely showed trends, and so renal complications. This was one of the things that was a byproduct of these studies with Embolics, was that renal complications were reduced, and they're really just mainly looking at brain. Okay, so here's some more examples. I've got I guess it was about 10 years ago. I think I got like $500 for putting a white paper out, and that was my last financial interaction 10 years ago with Edwards. I believed in the product so much that I used it pretty much on everybody at one point, and then I started kind of self-selecting because of cost issues. And I really didn't think it was that expensive, but I am pretty mindful of those things in the operating room. As a matter of just an aside note, at my hospital there are several heart surgeons, I think 8. I do most of the surgery, but my per case cost is the least, and profitability is the most, and with better outcomes, or at least equal outcomes. And we are barely missed STS Star 3 this year, and for a low volume institution. So we do about 250 hearts a year. So one of the big things that you always want to link this to, if you're trying to push a product, which Edwards was the financial consequences of, if you didn't do this, what would the financial consequences of one stroke be? And I think we all know that if they survive, it's higher. If they don't, it's lower. But still, regardless, across the board, it's very, very burdensome from an economic standpoint. I think with and I tell people this also, with the advent of off-pump surgery, it had the pump people also go back and look and see how they could help with improving neurological outcomes. And I don't know about you guys, but from when I was at Texas Heart from 2002 to 2004, to now, this incidence of pup head is exceedingly low, but it does still exist. Mama just did mama afterwards for a while. So here's some slides on theoretical costs of a stroke. With Embolic, if you do prevent a stroke, a type 1 event, savings of about $225,000. This was back in 2004. And of course, we know the financial consequences of renal morbidity, especially if they end up going onto permanent hemodialysis, or unfortunately now more and more are going on peritoneal dialysis, but still labor-intensive and cost-intensive. So, in summary, we've basically discussed most of these things, that they could be a substantial health risk, and this is part one of my talk, so we'll go through the next one, which is the little more fun part. Embolic's protection system is the first and only intra-aortic filtration system, not the only now. And in my opinion, and trends in most of these papers show that it is, that does improve patient outcomes. And it may save hospitals money. Okay. So I'm going to skip forward, and there's some moving really slow. Can we go to this way? Yeah. Okay. So that wasn't mine, that big chunk, but I had one just like that. You can't tell me that doesn't affect anything. I think I pulled up the wrong file.
Let's just do this. Here, watch.
There was one of mine. Yeah, I had some proline in it.
Where do you want to go to?
So we need to go down to.
Look there.
Hold on, let me go. Go back up.
Right here?
Okay, so let's go back.
Is this the one you want?
Yep, we can start with that.
Okay, there you go.
What's going on with this thing, Joe? Okay. Can you pull that
Yeah.
back up again? Go down. Start there.
Here?
Just click it. Okay, now. So I'm not going to ask you to have a show of hands of those that had experience with its use. I'm assuming most of us have, at least been introduced by the Edwards people. And in what scenarios were most of these used? I started out with all cardiac. Then I started using selection based on age, assuming that patients that were older would require it. The type of disease, was it coronary straight up, or is it a combination of valvular disease, mainly aortic? If it was mitral valve prolapse with no calcifications, I usually didn't use it then. I evolved my practice into some of those situations, and then what your aortic ultrasound findings are. So, as we know, it was pulled off the market, and so why was it recalled? So the FDA recalled it due to an issue initially with a metallic tip in a certain lot. There was like a half a dozen lots where these were, there was an issue with the tip. Now, the original rumor I had heard was they had to resubmit it to the FDA, their 510K or whatever, because they had not disclosed that it was heparin bonded. Well, that was not the case, because that was actually listed on. I looked up the original submission to the FDA, and they did mention that the filter itself was heparin bonded. So in trying to get hold of the Edwards people to really kind of nail down, other than the tip issue, that seems to be the main reason why it originally got recalled, and then obviously for financial reasons, Edwards pulled it off the market. Most recently, we'll talk about that. Now, it's kind of like Al Capone. They didn't get him for murder, but they got him for tax evasion, right? That's what they admitted. That's what they put him in prison for. So what was its ultimate downfall? Because I've been asking literally every quarter, when are you going to have it back? When are you going to have it back? I basically, when they first pulled it off the market, I'm at about 8 or 9 hospitals at the time. I got every Embolic filter I could find and put it at St. Luke's. There aren't any more. It took a while to get rid of the last extra large, but we finally did. So what was its ultimate downfall? There was in March 19th of this year, they were going to discuss the findings of this NIH grant-funded study. The lead investigator was Dr. Mack, former award recipient here, excellent surgeon, know him well as a surgeon, and actually had him teach me how to do hyperhidrosis surgery. Thank God I don't do that anymore. And they looked at the primary endpoint, which was freedom from clinical radiographic ischemic injury at 7 days for CardioGuard versus Embolic. So they looked at not only Embolics, but CardioGuard. CardioGuard's a totally different animal in that it is a dual cannula system that sucks blood off, filters it, and gives it back. So no statistical significance, but trends toward improved outcomes, or at least no ischemic brain injury. And this is all they're looking at is ischemic brain injury. Then that was the primary endpoint. Secondary endpoints, they looked at the magnetic resonance imaging, lesion volume. If you looked at CardioGuard versus the control, and then the Embolics versus control, what you can see is that there is less volume area affected in the brain when you use these devices, but again, they didn't find it statistically significant. So, and then they looked at an overall neurocognitive decline, and again, they didn't really see anything statistically significant there. But there is something organically that's happened in these, but they didn't show them to be statistically significant. So the randomization was stopped early by the NIH and deemed that a reduction in the primary endpoint would not be achieved unless they did thousands and thousands of patients at a prohibitive cost. Again, here we go back to cost. Well, if you look at it, they enrolled 383 patients. Kind of a small number when you're trying to prevent one stroke out of already a procedure that's out of 100, you're going to have 3 at most, okay? And then, but they did reveal that the devices did function as intended. That was in the second paragraph. In other words, they're designed to filter out stuff. They did. The Embolics was far more successful at embolic atheroemboli. The CardioGuard also works on gases as well. And then, but they didn't really see anything significant except a trend toward reducing delirium. Okay, well, what does that mean long term? And this is a further discussion of of that from Mack, and then his. I think this is one of the most telling comments from this discussion at the ACC with NHA was there's suggestive evidence that there may be a benefit despite not meeting the primary endpoint of this trial. So it does what it does, and I think more importantly even than that is it's safe. So if there aren't any contraindications of safety to using it, again, back to transcranial Doppler, again, to all these little things we can do, all these little things tend to add up or will add up to improve patient outcomes. So here's another article from the web that basically discussed the same thing. And we discussed CardioGuard already. So here's the newest, one of the newest released guys on the block for TAVR. Basically uses the same principle as the earlier filter wires that Embolics piggybacked off of for their intra-aortic device. A couple little maneuvers, but really does not appear to be too difficult to implant. They've put in many of these. We won't do the animation, but it's basically going for the right arm and from the cannulation side for the TAVR. They showed significant decrease in atheroemboli. All these graphs show that, and actually there's a lot of them on the TAVRs where you show that they pick up large emboli that you can see, which was one of the issues that they thought maybe with the Embolics was that you do such a good job cleaning the valve out from an open standpoint using TAVR techniques that maybe it really doesn't matter. So my questions because Joe Constantino and Lisa are here, but they're mainly the valve guys, and it's like the Embolics guys live in some dark closet somewhere in California, can't really get a hold of them, but the questions I have for them is why not have it available? I think the answer is obvious. I'm not going to make any money off of it. Cost issues. What does it really cost? Because because of that, there was no reimbursable code for it at the time. basically told every patient, if you get a bill from the hospital for $300, would you be willing to pay it if it'll prevent a stroke? Every one of them said yes. When I use this, I said that every time. It's kind of a little tongue-in-cheek, but patients want every available technique within reason to help prevent a complication, and we all know that the biggest one is stroke. I mean, most people say they'd rather be dead than have a stroke. And then some surgeons may decide to use it regardless whether it's been recalled by the FDA, because in my opinion, that's for safety. That's not for necessarily the clinical effectiveness, unless it's disparate. And I think that the trends have shown that this does work, and that I would still like to have it in my toolbox. Oh, okay. You didn't tell me there was a timer right there. Okay, so real quick, conspiracy theory. Webline search, I just did Clinton and streptase. I don't know if anybody knows this. Urokinase, very popular drug back in the late 1990s. Clinton nominated one of his guys, and about the end of that year, they investigated Abbott. It basically destroyed Abbott's urokinase market share, and one of the biggest donors for Clinton was Genentech, Activase. So how does this relate? We need to take the politics and emotion out of this versus the science. The science is here. Personalities in business. Some of us are scientists and physicians and surgeons. Self-governance versus government regulation. I think we've all seen an increase in government regulation, and I'm not one to believe that it's made anything any better. Capitalism versus socialism. A general broad category is like R&D, technology. There is a reason that technology advances in this country, and that's because of capitalism. It's not because the government wants to make it any better. And the ethical implications of not using the technology that we do have at our disposal, much less the ethical implications of not moving forward to advanced technology. So discussion, I don't think there's anybody here that doesn't want to think of this as, nobody wants any of this going to your brain. So the difference between clinical and subclinical manifestations, I think, was pointed out clearly by Macca that delirium is discussed in his paper. What does that mean long-term? Does that increase dementia rates? I don't know. I don't want to take a chance. What does that mean from a liability standpoint? If a stroke occurs, you have this available. Is there any liability from a company standpoint, physician standpoint, et cetera? Or as a college or profession, should we be held responsible for not pushing forth that agenda to do the best for our patients? So I think it basically boils down to costs, and we discussed these previously. I think that more data needs to be collected by the STS, and that was recommended at that talk. And I think the trends will likely be statistically significant with the numbers. And fortunately, technology does continue to advance. But right now, I've had a tool that's been removed from my toolbox. I'm a little upset about it. And I think more that self-governance should not be relinquished. And I think we need to go back the other way and advance our agenda to take care of our patients and not be held down to strictly and purely cost. I think you can do both. And I think I've proven that I can do both, at least on a micro scale at our community hospitals. So at the end of the day, what would you want for your mom? And I love my mom. So thank you very much. Sorry I went over time.
Okay.